diabetic with, a history of osteomyelitis and being in the nursing home. This is one of the more straightforward cases, but it brings up a couple of points. So first, I'd like to open this up to Erin and Mike. So what do you guys see when you see a case like this?
So this is Erin. I agree with what your stewardship team tried to recommend there. The vancomycin and the ceftriaxone seem a little broad and maybe a little more aggressive than you need to be at this point in a patient like this. So talking about the need for vancomycin is probably one place to start.
Right.
Yeah, this is Mike. I would agree with you, Erin. There's guidelines out there for cellulitis that were released by the Infectious Diseases Society of America that really breaks down cellulitis into purulent versus non-purulent, and that helps clinicians decide whether or not agents for MRSA are necessary. For a case like this where there isn't clear evidence of a purulent infection like an abscess, and the patient doesn't have risk factors for MRSA or is very, acutely ill, vancomycin is probably not necessary at all for her.
Right. So that's one of the things that you normally would either look for in the chart or ask the physician is, are there signs of abscess? Is there like an opening in the skin really is the thing to look out for. And in this case, there wasn't. It was really simple cellulitis. So the choice of agents, I think most of us would say this is a little bit overly broad. I mean, it's not that far outside the curve, but the vanco and presumptively their concern about MRSA probably isn't necessary. And then it depends really on the patient, but ceftriaxone for a 57-year-old woman with no history of medical problems may be overly broad too.
Yeah, Kevin, I agree with that. One of the other things, if you can't get a win with trying to have them just continue the vancomycin and just give ceftriaxone or beta-lactam alone, you may be able to convince the provider that, hey, if you are worried about, MRSA, the vast majority of cellulitis cases are related to gram-positive organisms. So you might be able to convince them to pull off the ceftriaxone instead to reduce unnecessary, extra antibiotic use as well. Because the vancomycin, for the most part, is going to cover all the same gram-positive pathogens, or the ceftriaxone is going to have similar coverage for gram-positive pathogens, which is the most likely organism that's causing it.
Right. Erin, I don't know about you, but I think there's an unwritten principle in our stewardship program that take half a win as a win. If you can get one of the agents pulled off in the beginning, ideally, but even afterwards, that's a win to us.
Absolutely. I consider it kind of a stepwise approach. You may not get everything on your first interaction, but if you can get rid of one of those on the first day, maybe give them another day and then come back and see if you can make your next intervention. But yeah, half a win is definitely a win.
Right. So that's really about the choice of agents. Somebody brought up particularly the IV vancomycin 1 gram Q12. So I don't actually have her. We weren't given her weight, but based on her weight in creatinine, 1 gram Q12 might be over much or might be excessively low. So whenever you see Vanco 1 gram Q12, and I'm sure every pharmacist here knows this already, but you gotta prick up your ears and look a little closer at whether or not the dosing was based properly. Now, many hospitals, surprisingly, the academic centers are the ones that lag behind on this. I think a lot of hospitals have just defaulted to pharmacist dosing of vancomycin or adjustment of vancomycin dosing, which per the literature is definitely better at keeping vanco dosing on target and a proper adjustment. So that is one thing to look at. Ceftriaxone, this dose of ceftriaxone is probably appropriate for a simple cellulitis. So let's go on to the next. Approach the physician. So Erin, how would you approach this physician who really wants to just stay on it because she got better on it?
Well, this is when I would, come back on my second approach with some guidelines, probably with me. Maybe, if in absence of guidelines, this case you have guidelines, but in absence of guidelines, come back with some primary literature that supports your intervention. In this case, I think there are guidelines available that you could show them and, talk about purulent versus non-purulent cellulitis and also focus on the risks of exposure to too many antibiotics. So you sort of approach it from a guideline perspective and doing what the guidelines recommend, as well as what potential harm are we doing to the patient by sort of overexposing and overusing antibiotics.
Right, right. And also, I mean, don't hesitate to use sort of the administrative pressures on physicians as a bit of a stick. You don't really want to make it, the primary reason you're changing, but if you keep this patient on IVs, guess where she's going to stay?
Yes.
She's just going to stay in-house. And she's now afebrile, normotensive, normal rate, normal white count. At least our caseworkers start, knocking on our doors when a patient seems to be very stable and is just here on IVs.
Mm-hmm.
So trying to come up with a plan to get them off IVs and onto oral agents always seems like a win. So I often offer the physician a sort of de-escalation plan that tries to take into account their concerns. And I think this attending physician's concern is pretty reasonable. She came in septic, right, or pretty close to septic, and he's worried that she'll get sicker again when we change her off. So one thing to sort of suggest is that, inpatient is actually the best place to change her to orals because you can watch her, right? You can watch her to see if she gets worse. So having them switch early to an oral agent to see how she changes may actually be a winning strategy or winning argument.
Mm-hmm.
I often say, why don't you switch her over to oral? You can watch her for 24 hours. If she's doing fine, then send her home. If not, then you can always switch her back to IV. That's often my sort of bargain with her.
Absolutely, I agree with that, and highlighting the option of if you do it now, you still have time while she's in house that you can watch and see what happens, and I think that's a really good point.
Right. And then you have to just be realistic. Some attending physicians are not going to be okay with that, and you just it's a percentage game we're looking at. We're not looking at getting every single win, just more. So the duration. Let's go on to the duration of therapy. How long would you guys keep her on, or recommend they keep her on antibiotic? Period.
You asking your discussants?
Yeah.
Yeah. It depends on their response, right? But if they're getting better and they're no longer febrile and you're beginning to see that improvement, I think the guidelines say that you can do around 5 days, right?
Right.
That's great, Erin. You could do, and I think that's useful too when you're talking to some of these providers, because it may take a little while for you to whittle down for them to receive, a narrower therapy, and by that time you could be pretty close to their stop date for the antibiotics too. So you might be able to convince them, hey, maybe they don't need to be in the hospital much longer. We can treat them for as short as 5 days. Right. I agree with Erin. I probably would do 5 to 7 days depending on how they're doing, but based on the scenario, a short treatment duration is probably appropriate.
Right. And I just want to emphasize one sort of infectious disease principle. It's not, the treatment duration often doesn't have to do with how sick the person was, but what kind of infection they had. So, you know, even though she came in SIRS, SIRS or sepsis, the actual underlying infection is cellulitis, which isn't a really huge amount of bacteria. So that's why 5 days seems to work fine, because there's not really a huge load of bacteria. It's just you're trying to get rid of the small population of bacteria that is causing it. So, so systemic issues and solutions, I think people have tried to put a lot of order sets in place to try to get people to properly make the decision or make the sort of diagnostic divide between purulent and non-purulent cellulitis, written guidelines, and sort of distributing them. And then just, you know, education whenever you're talking to physicians about a case like this.
Mm-hmm.
I'd just like to add, sorry, go ahead, Erin.
Oh, I was just going to say the other thing that I would add is a lot of times using your own hospital data is really helpful. So, you know, if this is a recurrent issue with a specific prescriber or a group of prescribers, gathering data, doing a little drug use evaluation, and then taking that to whoever you need to for support before it's either presented house-wide or presented to the group or the person is sometimes really useful.
That's absolutely right, and thanks for bringing that up. Yeah, it always seems like if you can show how things work or how things should work here at wherever you are, that's always much more powerful than, you know, well, this study said X. Except to ID physicians who are constantly looking for this study said X.
I just want to add to, you know, if this case was more complicated, like they were bacteremic or something, that our treatment duration would be different. So don't think that, you know, all cases of cellulitis, if they get better but they have, you know, staph in their blood, the management would be a lot different. So that's something to keep in mind as well.
And they probably should have done blood cultures on admission, but this the physician decided not to, or maybe I just don't have all the information because she came in, as I said, sepsis. So I'm going to go back to the poll just to make sure there weren't any other thoughts. No. So yeah, the key points to this are pretty much what we said. So the oral agents that probably would be most appropriate in this, because it's non-purulent cellulitis, it's Keflex, Amox, dicloxacillin, or clindamycin if they're penallergic. And really, I think it's pretty well established the transition at 24 to 48 hours, if the patients become stable, is very reasonable. It doesn't need to be like you have to wait 3 or 4 days before you switch to orals. And then a short monitoring period on oral therapy sometimes comforts a lot of physicians who are wary of you know, convert and discharge. So doing it earlier sometimes is more helpful. And 5 days. That's generally what the literature has shown, and in my experience, that's been the case too. It's cellulitis itself. It's a pretty short course of therapy. So just oops, it is decided not to work. Hold on a second. The infectious disease. So trying to give you guys materials to help convince providers of the appropriateness of a decision change. The IDSA recently updated their practice guidelines for the management of skin and soft tissue infections. So in 2014, they updated this. And as we said, it makes a very clear divide between non-purulent cellulitis and skin and soft tissue infections. And this really means, by non-purulent, they mean that there's no draining pus or clear pus pocket. And for mild and moderate infections, and honestly, almost all infections with non-purulent, almost all non-purulent skin and soft tissue infections fall into either mild or moderate. You don't need vancomycin. Severe, these are really necrotizing infections, which honestly, I think many of us would put in a totally separate category other than skin and soft tissue, non-purulent skin and soft tissue infections. This is your necrotizing fasciitis, your gas gangrene. These are really sick patients, people who are in septic shock or have severe underlying immunocompromise or end-stage renal disease. These are not your, patients with relatively few comorbidities and relative stability. So this is why the empiric broad coverage treatment with gram negatives, this is really for people who need surgical debridement, which is not most of those patients. And then, so there are two classes, non-purulent and then purulent. So these are your pus, your pussy infections, where you've got an abscess on the skin and a draining papule or something like that. And honestly, antibiotics are not the first line for this. It's incision and drainage and debridement, which are really your first line treatments. For mild purulent soft tissue infections, so people who just have a big carbuncle, you don't need antibiotics at all. It's incision and drainage, packing, really more than anything else that helps. In these cases, it's vancomycin and then probably transition to Bactrim that helps a lot. So look up these guidelines. They're totally free for use, and you can keep them in your back pocket to sort of help. Well, it also help educate yourself on what really is appropriate for various types of skin and soft tissue infections. And they include. What?
Sorry, Kevin. I'd just like to add one thing too. The concept that Bactrim or doxycycline would be a broader agent and therefore better may not always actually be the case for skin and soft tissue infections as well. For the non-purulent infections, oftentimes they're related to group A strep, and
right.
Doxycycline and Bactrim actually don't have as great activity for group A strep than a beta-lactam antibiotic.
Right.
So you may be giving these providers that are treating patients with a non-purulent infection with one of those agents may actually be doing them a disservice and placing them at high risk for failure. There was a recent study, I don't know, Kevin, if you want to discuss it, in the Journal of the American Medical Association, where they compared Keflex plus Bactrim versus Keflex alone for non-purulent cellulitis.
And it came out as equivalent. Yeah, but the outcomes on both sides were the same. So it really suggests you don't need it. So yeah, Mike brings up exactly the points I was going to make on this slide. So the organisms, these are almost 90+% of the organisms in these kinds of cellulitis. Actually, it shouldn't even be called cellulitis. Purulent. This is a purulent skin and soft tissue infection. But 90% of non-purulent cellulitis is streptococci for the most part. And these streptococci are very sensitive primarily to the penicillin and beta-lactam type antibiotics. So the treatment is usually, if you know that they have a non-purulent cellulitis, cefazolin as an IV treatment is totally fine. And then, if you're not quite as certain, maybe ceftriaxone, but people use penicillin, people use clindamycin, and if they've appropriately diagnosed it, it works out perfectly. And oral step-down agents are what we just said. Purulent cellulitis is the exact opposite. Most of these are Staph aureus, and that can be either MSSA or MRSA. In this case, incision and drainage is really the primary therapy. Antibiotics are adjunctive more than anything else. But culture is actually useful because of the fact that there is a difference between methicillin-sensitive and methicillin-resistant Staph aureus. And you can't really predict which one it will be. MRSA, community-acquired MRSA also causes a lot of abscesses as well. So you can't just assume it's methicillin-sensitive Staph aureus. And in this case, of course, everybody uses vancomycin as their first line unless there's some clear reason not to, like a significant kidney disease. Switching oral step-down should be based on what strain of staph it is, MRSA or MSSA. And in that case, it's Bactrim doxy versus Keflex and dicloxacillin. As Mike said, Bactrim and doxycycline don't have good streptococcal activity. So if you need to cover both streptococci and potentially MRSA, you're going to want to use two, probably Keflex and Bactrim. So that's, that combination is a lot of antibiotic. So another pitfall I wanted to sort of outline, though this is a little more for clinicians, is that early cellulitis and healing cellulitis, early cellulitis actually can sometimes look better than healing cellulitis. So it's often this bright red kind of almost pink spreading rash versus healing cellulitis, which is much darker and purple and can look really ugly. And the skin begins to flake and looks bad. Some providers will say, well, it's getting worse on antibiotics. This change, this darkening and purpling, that's not getting worse. That's the natural healing process of cellulitis. So sometimes you just have to make sure that they're actually paying attention to not just the visual change in cellulitis, but whether or not the patient's improving in terms of their white count, in terms of their hemodynamic status, fevers. If that's getting better, almost certainly it's not the cellulitis that's getting worse. All right. Any questions on this case? I'm going to open this up to the rest of the audience to see if you've got any questions or comments on what we've discussed. You can bring up, situations, variants that you've had with other providers to try to bounce questions off of us. I would also say that if you want to sort of ask us more in detail questions that require sort of longer amounts of text, you may want to send us the question over the mostewardship@worcester.edu email, where we'll be able to sort of parse it a little bit more in depth. You can just say in reference to case 1 of the case conference, and we'll know what you're talking about. I'm going to leave this up for another, we'll say 1 minute, if anybody's got any questions. But then we'll go on. Actually, if anybody, so people can still respond to this. Can you share this information afterwards? Absolutely. So what we're planning to do is have a little debrief email that we're going to send out, which highlights the points that we discussed and shares those resources. So it has the hyperlinks for the guidelines and such. So absolutely, yes. All right. So anybody can continue to ask questions on this question. I'm going to move on to the next one. Does anybody have any cases to discuss that they want to just insert into this case conference? We built in some time so that people can do this. If you want, write down your webinar screen name if yes. What I'm going to do is I'm going to leave this poll up, if anybody has any cases, they can write it on this poll everywhere question. And what we'll do is continue on through the case conference, and then I'm going to check on this a little, at the end of the case conference, and then we'll discuss any cases that you put down. I'm hoping this works right. Sorry, this is something new we're trying with poll everywhere. Okay, Mike, do you want to go on to discuss case 2?
Sure, yeah, this will be a lot shorter, but along the same lines. So this case is a 63-year-old male with a history of hypertension and congestive heart failure, as well as obesity, who's presenting to the ED with left-sided leg swelling and discomfort. You can see his vitals in the emergency department all look fine, other than a little tachycardia. His white blood cell count a little bit on the high end of normal, or maybe borderline based on your lab references. And then on exam, the leg shows chronic venous stasis changes with left greater than right side edema and some warmth. So the emergency department doctor starts him on vancomycin and Zosyn, and then admits him to the hospital. And then this patient gets queued on your list to review. So do you see any issues? What problems do you see with this? Feel free to enter them now.
The antibiotic doses. Rule out DVT. That's actually a really good point. DC, the antibiotics treat the CHF. And I think that's, you guys are picking up exactly on what we had sort of keyed in on. Right? Mike, does this person even really need antibiotics is the question.
Yeah, that's a great question. You know, he's got this history of congestive heart failure. He may not be very adherent on his medications given his elevated blood pressure. His vital signs shows that his O2 saturation is lower than what you would expect for someone that could either be suggestive of you know, congestive heart failure exacerbation, or maybe a DVT, as someone else mentioned, especially with that tachycardia. And the leg really isn't that impressive on exam either, with this chronic venous stasis changes. There's edema on both sides, with the left being a little bit greater than the right, but there's warmth but no real erythema. So absolutely, I think one of the challenges that you'll have to work with for the physicians, and this, I think this is hard sometimes as a pharmacist, and Aaron, maybe you can chime in about your experiences. Sometimes you also have to put on a hat of a clinician trying to assess differential diagnoses in addition to helping with antibiotic guidance recommendations too. How do you balance that, Aaron, and how do you approach it? Do you have physicians that sometimes give you a hard time about giving medical recommendations?
Absolutely. That is a balancing act for sure. And I would say probably the key thing there is to know your audience. You know, I think I mentioned this when we had our last webinar. You know, your approach is probably quite different if you're talking to a resident as opposed to an attending who's been in practice for 20 plus years. You know, for the older attendings, generally questions are much better than just coming straight in with, you know, making it sound like you think they're doing something wrong. So coming in is sort of a little bit, you know, just asking, you know, have you considered this? Does it, you know, this doesn't look like a cellulitis that I've seen before. You know, it doesn't. And I'm just wondering, are these antibiotics necessary? Have you thought about, you know, these other diagnoses? Always posing it as a question when you're talking to somebody who might be, or that you know is going to be a little bit more defensive, is probably at least that's an approach that has worked for me. You have to know your audience though, and it is a balancing act for sure.
Right. And realize that new attending, so like people just out of residency, they can also be pretty defensive as well. I mean, because oftentimes they're not quite as secure about their, they're not actually secure about their knowledge and their ability to discern diagnoses as much as, say, an older physician who's seen, you know, everything under the sun. So they can sometimes be just even more prickly than some of the older attendings, at least that I've found.
Yeah, that's a good point.
You might also be able to give them some supportive evidence too. We didn't document this here, but if the patient's weight had been up compared to previous admissions, you may state, oh, I noticed that their weight's also up and they have a history of congestive heart failure, could this have a similar picture to heart failure, to see kind of what their thoughts are about that?
And one approach that I found works sometimes is merely just asking, do they need antibiotics now? Because you oftentimes, as Erin said, there's a lot on the differential, and they may not have even written it down, but they may already be doing things like ruling out CHF and treating or ruling out DVTs and treating CHFs, right? They may be giving, along with the vancomycin, they may be giving Lasix, and also doing a CTPE protocol. And one thing you can ask them is just, you know, I know you're trying to figure out what's going on. Do you need to give the patient antibiotics right now? They seem to be pretty stable, at least on the vitals, right? They have a mildly elevated white count and maybe a little bit of tachycardia, but which can be explained by other things. They're not febrile, they're not hypotensive. And you can say, you know, we would maybe suggest ruling out the other things or confirming the other things before you start antibiotics. And I think one thing to point out here is just somebody brought up the antibiotic doses and the antibiotic doses. IV Zosyn at 4.5 grams Q6. I think most physicians wouldn't know, but there's a ton of sodium in this, right? 4.5 grams of piperacillin sodium is a lot of salt. So they may be sort of working at cross purposes to their own other treatments. So you can use that as sort of a backing argument as well. And I also don't think Zosyn 4.5 grams Q6 makes any sense for a person who's totally stable either, because it's higher than sort of the standard dose of IV Zosyn.
Do you want to add some more about that, Kevin, about the different doses? Usually people talk about 3.375.
3.375 Q6. And I mean, it really depends on what they're trying to treat. I've seen Zosyn 4.5 grams Q6 used primarily for people who they're worried about highly resistant organisms and who are also tend to be, you know, septic or shocky. So it's usually not this kind of patient.
It's usually the Pseudomonas dosing is the 4.5 grams.
Right. So if they had like a clear opening in their leg or history of diabetes, maybe you might think about that comparatively. All right. I think we've sort of discussed a lot of these points already, but we've already talked about the approach to the physician. Do you guys have any other thoughts to add to this case before we go on to sort of the learning point? So one question is really the duration of therapy. The one question to bring up to the physician is the duration of therapy. When they're not really sure what they're treating, sometimes the duration of therapy can go really bizarrely long because they're not sure if they're improving or not. You know, if this was CHF, then they probably aren't going to improve very quickly. So that's one thing to bring up to them is like, can you just at least think about discontinuing it at 48 hours if there is no real sign of response or sign of infection? And once again, taking a partial win is a win. Any other thoughts, guys?
No, I totally agree with that. You know, we would often, if we made the first intervention and they, you know, didn't really agree with what we had said, we would come back, you know, and try to do a reassessment at 24 hours or, you know, get them to agree at the 48 hours. But yeah, I totally agree with the partial win
right.
scenario.
So just from a technique standpoint, I know people keep sort of sheets of people that they've already discussed with the team, but maybe have an opportunity to rediscuss at some point in the future to just remind them that, oh, I need at 48 hours I need to go back to this person. Sometimes your EMR can do that for you, but I know people just keep manual sheets as well. All right, Mike, it's your show.
Yeah, so one of the other topics that we wanted to ask you is if there's certain antibiotic combinations that are more concerning or that worry you more than others. Yeah, this is also kind of a loaded question, I imagine, if we're asking it here. So most people are absolutely right. There are certain antibiotic combinations that we get more worried about than others. So maybe we can go on to the next slide.
Sure.
So which combinations should you avoid? So we try to avoid the following that was specifically in this scenario, and that's vancomycin, in addition to the other topics that we discussed related to the fact that he might not have an infectious etiology, or it could make his heart failure worse given the sodium load. There's also several studies that have shown that this combination of antibiotics in particular increase the risk of patients developing acute kidney injury. This is a slide from a meta-analysis from Clinical Infectious Diseases that demonstrates that there's a 3 times higher odds of acute kidney injury with this particular combination than vancomycin alone. There's a higher risk compared to vancomycin and cefepime and other antibiotics as well. Next slide. In your experience,
We'll of course send out that paper.
And is this something that we can use maybe to change their practice? What are your thoughts? And if you are aware of this, have you tried to use it to change practices?
We'll give us a second or two. Of course, we're going to send out these. Oh, bummer. It's not coming up as sentences. I think this might be a little confusing. Sorry, I think I set this as the wrong type of poll. Sorry. Mike, do you want to move to the next? I think it's doing a word cloud. It's not gonna. You're not gonna get a proper responses, I think.
We'll summarize some of the word cloud topics, I guess. Yeah, it seems like a lot of people are mentioning physicians' education being an important part. Acute kidney injury obviously is something that should be in consideration. I think reviewing the literature with them is also helpful, and some people mention the ICU. So I think that's an important point. It's a frequent combination that doctors in the ICU use. A lot of physicians are aware that aware of acute kidney injury related to several other medications that they use, but this is one that I think can be used as a reminder for physicians if you're trying to narrow antibiotic spectrum or reduce them down to one agent. Next slide.
Right.
So in terms of take-home messages for the second scenario, the combination of vancomycin and Zosyn is strongly associated with nephrotoxicity. Some patients mentioned, or some participants mentioned the ICU. There are some limitations to the data. Obviously, sicker patients tend to get more broad-spectrum antibiotics and are also more likely to develop acute kidney injury. But really, the consensus ID physicians is that this combination really should be avoided when we can. So we'll still use it, but if we have someone that may have chronic kidney disease, or we're worried that might be at high risk for acute kidney injury, it's something that we take into account when we're selecting antibiotics. And I think more importantly, you can use this data and literature to help persuade physicians to narrow antibiotic therapy. They're aware about increased adverse event rates. They should be aware that acute kidney injury increases hospital length of stay. So for hospitalists or patients that are seeing these patients every day, if you can convince them that this might be able to reduce their census and allow them to go home and see their families earlier, that can be a powerful argument. In addition, Zosyn really isn't very amenable for IV discharge as well. You can sometimes do the Q24-hour pumps, but a Q6-hour antibiotic is a pain for patients to infuse. So it can also hold up discharge as well. So trying to narrow the spectrum of antibiotic therapy earlier and observe them in the hospital may be a great place to do it as well. Kevin and Aaron, do you have other comments about it?
Yeah, I mean, it doesn't mean you can't use Zosyn. Doesn't mean you can't use vancomycin, of course, but just be wary of the combo. We still do use it. I mean, sometimes it is the sort of the broadest, most appropriate combo, especially for things like intra-abdominal infections or things where, you know, you're worried about enterococci, you're worried about anaerobic bacteria. The thing is, oftentimes those don't need MRSA coverage. So it's a, you know, it's a good reason to at least bring up the question, do they really need Vanco if they just need really Zosyn or piperacillin tazobactam? So that's just, it's just a thought. You know, you're sometimes stuck with your formulary. I know certain hospitals are cefepime places, certain hospitals are Piptazo places. If you're really constrained to Piptazo, well, you have to use it. But just, you know, you may want to make the team aware that there is this possible increase in nephrotoxicity. So keep them a little sharper watching the creatinine. Any questions on this case, by the way? I'm going to go back while we're waiting for anything like that. I'm going to go back and just see if anybody had any cases discussed. It doesn't look like anybody did. And it doesn't look like we've got any questions on this case, at least not yet. Once again, you can always send questions to the MassEC email. That's going to be it for this case conference. We're trying some variations on the case conference style just so that people, you know, based on feedback we got from the last one, if you found this useful, if you found this style of sort of conversational case conference useful, please let us know. If you think that it would maybe work a little better a different way, we can, you know, try to adapt that too. These are evolving you know, learning experiences. We're trying to make sure that you guys have as much opportunity to sort of ask your questions, bounce your ideas off of us as possible. Please, please, you know, use the conference feedback form for what it is. We want to know your thoughts on this. We want to know your questions and how useful this is to you guys. Hopefully this has been of use and you can use these pieces of information in your practice. What we're going to try to do is send out an email sort of summarizing the learning points in this conference and also directing you to those resources, the papers and the guidelines that we've referenced. Once again, we're going to try this, make this a regular thing. Look for the case conference next month, and also look for our special seminar on antimicrobial stewardship in community settings and resource limited settings, which will be next week on Friday. So I hope to see a lot of you there. I'm hoping this is a good and worthwhile use of your time. And if you have any thoughts, please let us know. Once again, you can always get back to us at the Missouri Stewardship, the MO Stewardship at Worcester.edu email, where you can ping any kind of thoughts or questions or case questions over. It doesn't need to be, you know, long form email with, you know, an entire HPI attached. It can just be a short, you know, we see these kinds of issues. We've tried to respond to some questions that people have already brought up to us, and we're going to try to keep, you know, keep focus on the questions and topics that people are interested in. So if you have anything, please let us know. All right. I think then that we'll say goodbye for now. The conference feedback will be open for, I think, 24 hours. And so if you can just send in your responses, that'd be very helpful. And it's been a pleasure. Each one of these is a pleasure. I hope that you guys have had a fun time.
All right, thanks everyone. This is Megan from MHA, and we will go ahead and close the webinar. But again, go ahead and finish up your polling. It will continue to stay open, but the webinar will close now. So have a great day, and we hope to see you at the next one.